Good evening, everyone. I am Dr. Suyash Bhar Sharma. I work in capacity of Senior Medical Advisor for Zydus Oncology and Hematology Division. Thank you, everyone, for joining us. I welcome everyone. For further proceedings, I'll hand over the session to Dr. Amit Khurana, sir. So over to you, sir.
Thank you, Dr. Suyash. Very good evening to all of you, and good morning and good afternoon to those people who are joining from the rest of the world. Today, our guest speaker for the day is Dr. Naval Davar from MD-ACC, Houston, USA. He's going to lecture us today on acute myeloblastic leukemia, an update from ASH 2022. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus Dedicated to Life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Naval Davar from MD-ACC, Houston, USA. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is 26th of March, Sunday, at 11 a.m., we have a webinar on flow cytometry, basics for the clinical hematologist by Dr. Monali Gupta from London, UK. Let me introduce the discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from PGI Chandigarh, Dr. Alka Khadwal from PGI Chandigarh, Dr. Amber Garg from PGI Chandigarh, Dr. V.A. Arun from INHS Aswini, Mumbai, Dr. Avriti Babeja from Cancer Research Institute, HIMS, Dehradun, Dr. Dharma Chaudhary from Sanar International Hospital, Gurugram, Haryana, Dr. Dibyendu Dey from the unit of Vedanta Medical Research Foundation, Nava Raipur, Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, Dr. Mirza Salim Amjad from Kaman Hospital, Chandi Mandir, Dr. Rahul Arora from RST Hospital, Nagpur, Dr. Ramaswamy NV from Esther Med City, Kochi, Dr. Sazia Gulshan from PLS Hospital, Kolkata, Dr. Shriram Kane from Dr. Kane Hospital, Nagpur, Dr. Subhadeep Bol from NRS Medical College and Hospital, Kolkata, Dr. Vishwadip Khushu from AIMS, Nagpur. Let me introduce the guest speaker for the day, Dr. Naval Davar from Houston, Texas, USA. Dr. Naval Davar needs no introduction, but it's my formal duty to introduce him. Dr. Naval Davar is Associate Professor and Director of the Leukemia Research Alliance Program in the Department of Leukemia at MD Anderson Cancer Center. He is a clinical investigator with a focus on molecular and immune therapies in AML and other myeloid diseases. He is PI for over 25 ongoing institutional, national, and international clinical trials in these diseases. These trials focus on developing a personalized therapy approach by targeting specific mutations or immune pathways expressed by patients with AML, evaluating novel combinations of targeted, immune, and cytotoxic agents, and identifying and overcoming mechanism of resistance. He has published over 260 peer-reviewed research articles. He is on the editorial board of numerous hematology journals. He is a co-director of the MD-ACC Hem-Onc Fellowship Leukemia rotation, and he mentors numerous fellows and junior faculty. He is going to lecture today on acute. Over to you, Dr. Naval Davar. You are muted, Dr. Naval.
Yeah, thank you. Thank you very much. And it's a pleasure to speak to you today about the updates in ASH for our AML. A lot of work happening in the acute myeloid leukemia field. It's a very, very exciting area of hematological malignancies, probably the most exciting at this point with the progress that's happening. And it's always a pleasure to speak to the colleagues in India and through the Mumbai Hematology Group to discuss the updates. We've been doing this almost every 6 months. So I'm going to kind of keep it more general on how I treat AML in 2023 and incorporate some of the updates, because I think from a practical perspective that is more usable for treating hematologists and clinical hematologists. Some of the updates in ASH are very heavily translational or basic, which maybe in the future will lead to more clinical directions and leads. So I will be focusing more on what is, or hopefully very soon will be, in the clinic. So this is a slide I've shown many times. This shows the progress that's happened, at least in context of US FDA drug approvals over the last 6 years, in fact, from 2017 to 2023. So not a long span of time, but we've had actually 10 drugs approved now in this period of time. This is great progress. This includes targeted therapies, 2 FLT3 inhibitors, 2 IDH inhibitors, venetoclax, which is probably, as a single agent, the most impactful new addition to the AML landscape, and is being combined with many, many different modalities that I'll talk about. Maintenance therapy for the first time getting approval in the US and ex-US for acute myeloid leukemia after about 3 decades of efforts with maintenance in the form of oral azacitidine CC486, and then other agents as well, such as CPX glastigid. And there are also other drugs that hopefully will get approved in the near future, such as new FLT3 inhibitor quizartinib, which is one of the most potent ones in the frontline setting, and I'll talk about that. So the progress, I think, will continue. We're kind of at the start of what we consider the therapeutic revolution of AML that started 5-6 years ago, and hopefully will continue until our cure rates are really dramatically improved. That being said, today the cure rate in AML still remains in the 30 to 40% range. It was about 20% a decade ago, so that's better, but we're far from 80, 90% or higher, where ALL and multiple myeloma are now achieving. So there's still a lot of work to be done. A lot of these drug approvals have also led to shifts in the classification on prognosis, and I think it's important here to highlight that prognostic classifications are heavily dependent on changes in treatment. Just yesterday evening, I was in a meeting, and a lot of people treat the ELN or NCCN guidelines as Bible, but you have to really realize that these are heavily dependent on treatments. And so as the treatments progress and the more rapid the pace, the less these prognostic you see the changes that occurred. The big change was that FLT3, that historically was distributed again across intermediate and adverse, now has all been moved to intermediate, because with the incorporation of FLT3 inhibitors like midostaurin, and I think even more so with second-generation FLT3 inhibitors like quizartinib in the frontline setting, we are seeing that FLT3 no longer carries the quote-unquote adverse, where adverse includes things such as complex cytogenetics, chromosome 17p deletion, inversion 3q, TP53, and FLT3 is not behaving that adverse anymore. It's moved to an intermediate group. And in fact, I think with more progress, incorporation of second-generation FLT3 inhibitors, transplant, and potentially maintenance post-transplant, FLT3 could even move into a favorable group. This is what we saw with Philadelphia-positive ALL, which was unfavorable 2 decades ago, intermediate, and today really with blinaponatinib, we consider this to be one of the best groups of ALL. The other big change that we're seeing is that the more dependence on biology and molecular mutations rather than morphology to identify entities such as what we call MDS-related or secondary AML. So historically, this was a group that, based on existence of background dysplasia morphology, we used to be able to call these MRC, MDS-related changes with AML. Now, both the WHO and the ELN are requiring the presence of either a clear cytogenetic or molecular biological identifiable entity, such as a mutation in ASXL1 EZH-RUNX, to be able to call the patient MDS related. So a shift from morphology, pathology, which are sometimes more subjective, to molecular and cytogenetics is being seen across the WHO, ICC, ELN criteria. And I think this is a good thing, helps to replicate and compare data across different centers and even across different countries based on objective criteria. So I always like to mention acute promyelocytic leukemia. There are always new fellows and residents who are listening. This is the one entity in all of oncology, I think, that one should never miss. You cannot afford to miss APL. The cure rate is extremely high, close to 95, 96%, and it is without intensive chemo. So really, this is the poster child of not just AML, but pretty much of all of oncology treatment. We were hoping we would be able to replicate this with other targeted therapies, but this, I think, is a very unique subset. The treatment here is atra-arsenic. We do use gemtuzumab, 1 dose in patients who have elevated white count greater than 10,000 at any time during the first 28 days or first cycle. Some centers have used idarubicin. Idarubicin is also a good choice in patients with high-risk APL defined as elevated white count. Gemtuzumab seems to be a little bit better, but either one I think is a good option. And then the atra-arsenic regimen is shown here, extremely well tolerated. Numerous publications now over the last decade, the seminal one being this one. This was published in New England Journal in 2019, showing the 5-year survival, event-free and overall of greater than 95%. So this is really an outstanding group. That being said, early mortality remains a problem in APL, and that is what we should be focusing on, that early period of DIC hemorrhage, admitting these patients, close monitoring, avoiding fluid overload. This can actually cause a lot of disastrous complications, especially in APL with atra, where they tend to retain fluids quite strongly. And then usually we are very delicate in the treatment in the early period. We may just start atra alone, hold off on the arsenic. You don't need to push treatment in APL. They're so sensitive that even if you give 50% or 30% of the initial treatment, you will be able to catch up later. So usually if you're running into problems, DIC, LFTs, etc., it's okay to hold treatment for a few days while you stabilize the patient. This is a complete opposite of FLT3 AML, where sometimes you have to push through treatment because the disease is causing problems. In APL, we're very comfortable to wait for a few days to stabilize the patient, because eventually everybody will respond to atra-arsenic. So just kind of key messages for APL, which I think is very, very, very important. And we have a number of patients. We just published our update of our ongoing APL study, 200 frontline patients over the last 15 years with a survival of 97%. So really a group that can do well. Now, for the rest of the patients, the treatment is based on, we still use the terminology of suitable and unsuitable. I don't like fitness. I like the terminology suitable, unsuitable. And I'll talk about that a little bit more, because suitability incorporates 2 factors. It includes demographic and patient fitness, and it also includes biological fitness. And more, we are using biological fitness who actually will benefit from intensive chemo. We should give them intensive chemo. Not we have to give everybody intensive chemotherapy, except if they're really, really frail and have high mortality. And the case in points are TP53 complex cytogenetics in version 3, where they may tolerate intensive chemo. You may have a 40-year-old who could tolerate it, but is it going to benefit that patient? And the answer at this point seems to be no. So why give them intensive chemo with a 28, 30-day admission, mucositis, diarrhea, all of the other complications, if there's no biological benefit? So we're moving from that traditional physical fitness to more of suitability that incorporates many different factors. For those who are suitable for intensive chemo, we at MD Anderson have been using FLAG-IDA-CLIA, incorporating pure analog. This data has been replicated and confirmed in randomized studies by the Polish groups, as well as the British, that the addition of pure analog does improve EFS and OS. And we are now incorporating a third agent, either venetoclax if there's no targetable mutation, or a FLT3 or IDH inhibitor if there's a targetable mutation. We don't do both. When we try to do both, it causes cumulative myelosuppression. So we usually will choose either targeted therapy if there's a targetable mutation, or venetoclax. And then once they're in remission, we proceed with allogeneic transplant. For a broad majority of these patients who are fit for intensive chemo, and except for those with core binding factor and isolated NPM1, pretty much everybody who falls in intermediate adverse per ELN NCCN, we are still leaning towards allogeneic stem cell transplant. Of course, using flow MRD, there may be some changes in that decision, but we do get our transplant team involved within the first few days, because that is most likely where we will be heading for the majority of these patients. And then post-transplant, we usually are using maintenance on ongoing trials at MD Anderson. So one of the other subsets that is good, but is not as good as APL, is what we call core binding factor in version 16.821. This makes up about 10 to 15% of AML, so it's not a rare subset. We do see this group quite frequently, 2 to 3 patients a month, usually at MD Anderson. And the key message here is that gemtuzumab, CD33 antibody drug conjugate with a calicheamicin-based conjugate, seems to really improve outcome in this group. Now, many people argue, and the NCCN actually also does allow gemtuzumab to be used across the board in both favorable and intermediate AML. However, when you look at the details of the data from the multiple phase 3s, the benefit is most striking in the core binding factor. There is some marginal benefit in the intermediate, but here we had to make a choice. Do we want to give FLAG or FLAG-IDA with gemtuzumab, or do we think FLAG or FLAG-IDA with venetoclax or FLAG-IDA with FLT3 are more impactful? And based on the preclinical and the emerging clinical data, we chose to focus incorporation of venetoclax and FLT3, and I think our decision is appearing to be correct. These appear to have more bang for their buck than gemtuzumab for the general AML. But for the core binding factor, I think gemtuzumab remains the best drug to be added to the backbone of intensive chemotherapy. This data was shown both with 7+3 addition of gemtuzumab, and the British MRC has shown FLAG-IDA or FLAG with gemtuzumab was a very powerful regimen. So this is the meta-analysis that has been well presented and published. It's looked at 3,000 plus patients across 5 randomized studies done in different countries in Europe. And the key summary that comes out is that in the favorable, which basically includes inversion 16-821 and isolated NPM1, the addition of gemtuzumab clearly improved the survival, 20% absolute benefit. You don't see that much in AML studies. So here I really think strong rationale to add gemtuzumab if you identify that group. In the intermediate, as I said, there's some benefit, but I think the incorporation of venetoclax or FLT3 instead is going to be more impactful based on the data that I will show you from our group. And then in adverse, really no benefit. So we definitely would not recommend addition of gemtuzumab. With gemtuzumab, if it's available, the way we have done it in our studies with the FLAG gemtuzumab, we usually will add the gemtuzumab during the first cycle and then the third and the fifth cycle. So alternately, we do a total of 3 doses of gemtuzumab, 3 per meter square, capped at 4.5 milligram. With the 3+7 GO as well, they do the 3, but usually those are done early on. So we stagger them because we're adding the fludarabine based regimen. This was published by Dr. Borthaker from our group a few months ago in the American Journal of Hematology. We have about 150 patients treated with the FLAG gemtuzumab with a 5-year survival of 84%. So this group also can do quite well. We transplant less than 10% of them. The decision for transplant is heavily based on molecular transcript. So patients who achieve less than 0.1 or even better complete molecular remission by the end of the 3rd intensive FLAG-based therapy, we do not consider allotransplant. Those who have a persistent molecular greater than 0.1 after the 3rd cycle, we will follow. And if they continue to manifest a persistent one by the end of the 5th cycle, then we may consider transplant or we may consider maintenance. I would say majority of these patients will eventually eradicate their molecular transcript. Less than 5% remain positive, and those are the ones where we may consider allotransplant. In the relapse setting, everybody with core binding should be considered as a high-risk relapse patient. We published many years ago that relapsed core binding factor does almost as poorly as relapsed AML without core binding, and so transplant would be the path. But in the front line, very, very, very few, less than 5% who maintain positive molecular transcript after 5 to 6 cycles of intensive chemo, we may consider transplant. So now talking about the incorporation of venetoclax. We have 2 studies ongoing. One is what we call the CLIA venetoclax, cladribine, either rubicin, cytarabine. You see the dosing and regimen here. And then the other is the FLAG-IDA venetoclax. The CLIA venetoclax was most recently updated at ASH. That's why I'm presenting it here first. We are alternately enrolling to both. We don't think one is better than the other. One of the key points here, though, is to note with the CLIA venetoclax, we started with only 7 days of venetoclax, as you see from day 2 through 8. With the FLAG-IDA venetoclax, we were doing 14 days, days 2 through 15. However, recently, just about 3 months ago, we amended the FLAG-IDA venetoclax also to drop it to 7 days because we found that more than 7 days was not adding anything in terms of CR, CR/CRi, MRD negativity, event-free survival, CR duration. We looked at all of these across 2 studies, and there was a little bit more myelosuppression. So 7 days of venetoclax with intensive chemo, whether you use CLIA, FLAG-IDA, is sufficient to give that boost without causing very severe myelosuppression. Of course, venetoclax dose is 400, a standard, but can be adjusted based on the azole that is used. And that's very, very, very important to remember that if you're using an azole, the venetoclax must be adjusted accordingly, because otherwise you will run into super therapeutic doses with severe myelosuppression. So here is the survival. I'm not going to go through the details. This was presented and was also published last year by Dr. Kadia from our group in Lancet Hematology. For those of you who want the details, you can look it up, Tapan Kadia, Lancet Hematology. This is the 2-year survival, early, but 71% is a very good number. Historically, we have seen between 50-55%, even with CLIA flag IDA at MD Anderson. So we think that this is really improving the outcome. We will have more follow-up in the next couple of years. We continue to enroll. So I think this will eventually lead to a sizable data set that will be usable. And the NCCN also has added flag IDA venetoclax recently as a potential regimen that could be considered in frontline AML based on these data sets. So to really try to analyze this, of course, you have two options. One is randomized study, and I think it's becoming more and more difficult with good reason to ethically conduct randomized studies in AML. The field is changing rapidly, and by the time randomized studies are being set up, we already are seeing new agents being approved and incorporated. So it becomes very difficult, and I think it will continue to become very difficult to do these true randomized studies like we did 2 decades ago, because there is no therapeutic equipoise. What that means, again, for residents and students is that when a doctor walks in and sees a patient, to do a really good randomized study, you in your mind and heart of heart should believe that these two arms are equal. If you don't, then you already are biased towards a particular arm. And this is actually what led to problems with approval of quizartinib and led to failure of some of the AML studies like the azacitidine and the azacitidine. Because once people believe that a particular regimen is better, they are likely to try to enroll to that, and patients who go into the other arm often will get dropped off and move to standard of care, incorporating the new agent. So I think it's going to be very, very hard, and we're already seeing failure of phase 3s because of this lack of therapeutic equipoise, where physicians, based on emerging data, already believe a particular combination or regimen looks like it is going to be better and want to get their patients on that. So another approach then is to do what we call synthetic cohorts or real-world propensity analysis, where you incorporate patients treated in the similar setting, so here at MD Anderson, in a contemporary period of the last 5 to 7 years, and compare them to the new regimen that you're using. And so these were all patients enrolled on frontline trials within the last 7-8 years at MD Anderson, similar physicians, similar setup, similar logistics. And the question here was, do you see an improvement? And actually, it's quite clear, and the numbers are pretty good, 194 versus 85, who got intensive chemo alone, CLIA or flag IDA, versus those with CLIA flag IDA plus VEN. And you can see the MRD negative CR is improved clear 20%. So that's pretty good, as well as in ELN adverse risk, where we need the most benefit, you really see that improvement clearly. Now, I have to say that we don't see this in TP53. In fact, the one group where we don't recommend or not using a flag IDA VEN, CLIA VEN is TP53. They continue to do poorly, but all the other ELN adverse, that includes your RUNX1, your ASXL1, the EZH2, the people with the secondary mutations, all of them do seem to benefit deletion 7, deletion 5, except TP53. So I think this data is quite impactful. As you see, these survival curves do show good separation, and the overall survival here is looking better with the addition of the venetoclax. And based on this, as I mentioned, the FDA has now just recently, 2 months ago, incorporated flag IDA VEN as an option to be considered for frontline AML, depending on the center and the expertise of the physicians. So I would think in India and other regions, this is a regimen that can be used. Now, that being said, a couple of important points before we move from that, because I've got a lot of emails of treating physicians in India and other countries using this. Number one, this regimen is myelosuppressive. There's no doubt about it. It is highly effective, but it is highly myelosuppressive. You must admit those patients for the first 28, 30 days. The other is we almost never use it in anybody above 60. Even 60 to 65, it really does start adding myelosuppression. So I think it's a great regimen for those below 50 and 50 to 60. You have to really look at the fitness, the logistical support, the ability of the patient to come to hospital quickly, etc. And the third is we absolutely always start all of these patients on prophylactic antifungal, antiviral, antibacterial. The risk of infection is quite high. Now, that being said, if you do all of these things, you appropriately select patients, you monitor, you have good expertise with venetoclax and intensive chemotherapy, the early mortality in our hands was 2%. So it can be delivered well. But again, this usually should be in a big academic center with hematologists with good expertise in this. I would never do this in the community center or a smaller center that does not have a full infectious disease, if needed, ICU, close monitoring, hematologist on staff, things like that. So just some practical considerations. Great regimen, but has to be done in the right setting by the right people. So the next is using venetoclax in lower intensity therapy. Now, this one, of course, there's much more data. This has now been used in thousands of patients across the world. This was the seminal phase 3 study that led to the approval, AZA venetoclax versus AZA placebo. We've all seen this data many, many times. We don't need to highlight it. Important to note that the median age was 76. So these were truly older patient population, going all the way from 49 years up to 80 years or even 90 years of age. So this study did require patients to be really older or unfit for intensive chemo by clearly documented criteria, was not subjective. Now, since then, because of the success of this doublet in achieving high CR, CRI, CR, and the ability to move patients even to transplant, this age bar has slowly been moving down, and people in the US, including our group and many, many others, are using HMA-VEN routinely for 65 to 75 years of age. Because again, the question is, if I can get 67%, 70%, 75% CR/CRI, why should I push intensive chemo in my 68-year-old, where maybe I can get him through, but 10 to 15% is the expected early mortality. Even if there's not a mortality, they're going to have mucositis, diarrhea in the hospital, hair loss, and many times by the time they finish, they're no longer transplant candidates because of all the hits and the negative impacts of intensive chemo. So why not do HMA-VEN and then still move to transplant if that's your goal? And in fact, that is a thought process that is now really happening more and more with trials looking at that in US and Europe. The important point here is the response rate, about 70 versus 30% overall. The true CR rate is not as great, and that's something that we are using to try to develop the new combinations to see, can we improve the true CR rate, whether it's with new regimens like AZA-VEN with FLT3 or with IDH inhibitors, or with pure analogs like cladribine, low-dose Ara-C-VEN. So we will use that usually as the best benchmark, because your CR/CR is already 80%, 70%. It's hard to really show improvement there. The other thing is responses in general are similar across molecular groups, but they're not the same. TP53 does have a lower response rate, and this also pans through into the survival, which is quite poor in TP53. I'll show you some of that data that was presented at ASH a little bit later. This is the updated 5-year follow-up, or 4-year follow-up. Actually, it was presented by Keith Bratz at ASH. So it really depends on whether you want to see this as a glass half full. So the glass half empty part is, we were a little bit disappointed to see that at 4-year follow-up, the curves continue to drop, and the survival with HMA-VEN was 23% versus 8% for AZA. So it's good. 23 is better than 8, no doubt, but it's 23%, right? And that's not what we were hoping when we started seeing the early HMA-VEN high response rates. The good part is, 25% of older unfit AML can actually be alive. A decade ago, that was less than 10%. But I think to us, at least at MD Anderson and to many other AML clinical investigators, what this shows is that there's a need for improvement. The backbone is now better, but far from where we want it to be. And a decade from now, if we're still at 25% 5-year survival, I think this will be a great disappointment and a failure of the AML clinical investigational field. So we really need to improve on this. This is just a first step towards getting hopefully closer to 60, 70% in the future. Now, from a practical point, I'll go over a couple of important things that I think will be very applicable, because I know in India it's being used quite a bit, venetoclax. We get a lot of emails and calls about this. So the first thing is the responses are usually quick, but not always. So most patients will respond in the first cycle. As you see, 65% of those who will respond in end of cycle 1. However, there is a continuous response that can be seen. So from cycle 1 onwards to cycle
Something went wrong.
Hello?
Yeah, we lost you. Something went wrong.
Yeah, something went wrong.
Yeah.
Okay, let me share again. Yeah, let me share again here. Do you see it?
Yeah. You have to make it full screen.
Let me see something. Let me stop and do it again. Okay. Okay.
Yeah, perfect.
Okay.
Yeah.
All right. I think I was on this slide, right? When it cut off.
Yes, I think the previous one.
Okay.
One before.
Yeah. So I'll just start again here. So this, you can hear me, right?
Yes, yes, absolutely.
Okay, so this is just looking at time to best response. And as what I was saying was that most patients will respond after cycle 1, 65%, but you do see that between cycle 1 and 3, there's another 25%. So 93% respond by the end of cycle 3 or 4. So in practice, I tell my patients that it could take 3 to 4 cycles to achieve the full response with HMA-VEN. We should not be depressed or pull the plug after one cycle if we don't see a CR/CRi. Now, that being said, this is obviously has to be taken in clinical context like anything else in medicine. You know, if the blasts were 60% at baseline and end of cycle 1, they're 60%, end of cycle 2, they're 70%, then I think that's a different story. You probably are not going to see a response. Most of these patients who had a CR/CRi later on did show some kinetic reduction in blast. So let's say you're 50% blast, end of cycle 1, you're 30% blast, end of cycle 2, you're 10% blast, right? I would not stop therapy. This person is responding, it's just taking longer. And what was really interesting and maybe a little counterintuitive, at least to me, to see was that those who responded late continued to have a similar survival to those who respond early. So even if it takes a couple of cycles and the blasts are slowly coming down and you achieve CR/CRi by cycle 4 or 5, that's okay. The survival is actually the same as you see on the survival plot. So I would just stick with it as long as you're not seeing clear progression or complete lack of response. So that's an important clinical point. The paper is published as well for those who want to look at the details. The next question is, how do we further optimize HMA-VEN? So the biggest thing here is cytopenia management, right? And a lot of people, I think, got confused or misled by the label of low intensity therapy, because that means people are used to thinking of HMA alone or low-dose RC alone. And this is not that. I mean, yes, it's lower intensity than 3+7. There's no anthracycline. You don't get mucositis, severe diarrhea, severe endotoxin shock, things like that. But it does cause more myelosuppression than AZA alone, decitabine alone, or low-dose RC alone. What you do see is that among patients who achieve CR/CRh, grade 4 cytopenia is seen very frequently. Almost 70% of those will have this at some point with AZA-VEN, and cycle delay is also very, very common. So a greater than 2-week delay was seen in 2/3 of the patients who were getting the HMA-VEN as compared to AZA alone, where 2/3 did not require cycle delay. Now, the big question that comes up is, do we have prospective data to show that a shorter duration of venetoclax maintains efficacy while allowing better count recovery, less prolonged neutropenia and infections? Unfortunately not. There's a lot of discussion. I was at a meeting in Munich just a few days ago, the International Society of Acute Leukemia, and some of the European groups are thinking of such a study of 14 versus 21 versus 28 day event. That would be a fantastic study. Because in practice in the US and at MD Anderson, we have treated already more than 250 frontline patients. And we have clearly seen that reduction of VEN down to 21 days in cycle 1 and 14 days cycle 2 onwards is very, very effective. We don't see a reduction in MRD negativity, CR rates, CR/CRi rates, and we see much better count recovery. But it would be good to prove that prospectively so that the label can actually be changed and not cause confusion in centers across the world. That being said, in the VIALE-A, we did see that there were a number of patients who were dropped 21 days because of prolonged neutropenia greater than 14 days in cycle 1. And in fact, those who were dropped have the same survival, actually maybe a little bit better. The p-value is definitely not significant, but this curve is actually riding a little higher, making the point that in the appropriate setting of remission being achieved and persistent neutropenia going down to 21 days of venetoclax is absolutely safe. You're not losing therapeutic efficacy and may actually even be better over time. And that's been our practice. We usually do a day 21 to 28 marrow in cycle 1. If the marrow shows either remission or even hypocellular insufficient marrow, we stop venetoclax and let the counts recover. For the next cycle, we drop down to 21 days. If we're still seeing prolonged count recovery, then we may even drop down to 14 days in the subsequent cycles. So that's an important point to note. The other important thing to note is that when you achieve a response, it's quite durable. Those who achieve a response, majority of them do continue on for 1.5 to 2 years. Median was 13 cycles of treatment, so about 1.5 to 2 years. And of those who respond, about 76% went on to receive greater than 6 cycles of treatment. Many of those with reduction to 21 days or to even 14 days of treatment, as you see in the majority of the patients, usually beyond cycle 4 and 6. And that's been our experience too, that after cycle 4 to 5, where we are coming down to 14 or even 10 days with Ven. So one of the big messages from ASH that came out is really that you don't need to push the venetoclax duration. We usually start with 21 days in cycle 1, and we're quickly dropping down to 14. Some studies are even looking at doing 14 or 7 days of venetoclax from the beginning. There was a study from France that showed 7 days of venetoclax with 7 days of AZA, called the 7-7 regimen, actually gave very similar response rates. And for your really old patients above 75, 80, that could be an approach. So I think this would be good analysis and study maybe to be conducted in India for the population there to see how many days of venetoclax is really needed. And my guess is it's going to be somewhere in the 7 to 14 range per cycle. That's probably going to give you a good response without causing significant myelosuppression and toxicity. So something to think about. So what about use of growth factor? That's another thing we get a lot of questions on. There's been this hesitancy and concern in the community about growth factor stimulating leukemia, in spite of the fact that a lot of papers have now actually shown that that is not occurring. And we do use growth factors in certain regimens from the beginning, like FLAG-IDA, CLAG-M, but there still remains this concern. So this analysis was undertaken from the VIALE-A, looking at patients who got AZA-VEN versus placebo AZA, and how many of those were the growth factors. So the first thing you see when you look at the right is that the proportion of people who get growth factor with VEN AZA is high, 50%. So of the 190, 93 got a growth factor here. And with placebo AZA, it's lower, only 10 on 41, so about 20%. Makes sense. HMA-VEN is more myelosuppressive, so obviously the treating physicians felt that they needed the growth factors more. The other important thing is that these were all given only after achievement of CR/CRi. And if you look at the point in the bottom in the VIALE-A, it shows that about 50% ended up receiving growth factor, as I mentioned, based on the numbers on top. And in the low-dose RC then, which we don't use as much, but was done in Australia, similar number required growth factor. So the big question then is that does that impact your duration of remission or the duration of cytopenia or the frequency of febrile neutropenia? And in fact, quite significantly, it seems to reduce the duration of post-remission grade 3 or higher neutropenia. If you look at the red circle there, it was 12 versus 16 days. Now that's a median, but that's a pretty big number. So 25, 30% reduction in number of days of cytopenia. And then if you look at the febrile neutropenia, that also seems to be reduced, 8 versus 10.5. Now this was for the AZA-VEN. The low-dose RC-VEN, it wasn't as clear. Maybe the numbers were smaller, or maybe there's a different biology. And then most important is, does this impact your long-term outcome and survival? And here I would focus on the two blue lines. These are the two AZA-VEN lines. So the one on top is the dark blue, is those who got growth factor at some point, and the lighter blue below it is those who did not get a growth factor. Now, people see this and it asks a lot of discussion about, oh, they actually did better. The numbers were not significant to actually show that. But what it definitely shows is that you can use growth factors safely. It's not going to impact the duration of remission or survival. And maybe it actually does reduce the rates of remission, death from infection and febrile neutropenia. So in our practice, if we see that there's no count recovery by day 35, end of cycle 1, even after holding the venetoclax on day 21. So we do a marrow day 21, we hold the ven. If the marrow shows remission, hypocellularity. If we see still counts are not recovering in about 14 days, so by day 35, 21 to 35, then we will use Neupogen 4 or 5 days to boost the count and then proceed with the next cycle. Some centers are even more aggressive. They just use Neupogen on day 28 right away to try to keep the cycles tight every 5 weeks without going to 6, 7 weeks. I think that's reasonable as well. The bottom line is it is safe to use Neupogen after confirming a marrow remission, and it does not impact the outcome, may even potentially have benefit of reducing infection-related death. So here now we look at the exposures across different CYP3A4 inhibitors. This is very important because at least in the US and at least in MD Anderson and most of the biggest centers in the US, we are routinely using a prophylactic second or third generation antifungal, posaconazole, voriconazole, isavuconazole. And this really has a big impact. So when you look at the predicted value of venetoclax, right, with a moderate strong CYP3A inhibitor, what we saw is that with a moderate like isavuconazole, there was a doubling of the venetoclax PK. So you had to reduce the dose by half. So normally we go from 400 to 200 if we're using isavuconazole. If you're using a stronger one like voriconazole, we usually go down to 100 because there was a 4-fold increase. And then with posaconazole, which is the strongest, there's a debate about 70 or 50, but more and more we have started going to 50 of venetoclax. So posaconazole 50 for 14 to 21 days, voriconazole 100 for 14 to 21 days, and isavuconazole or fluconazole, it's 200 for 14 to 21 days. Many countries are also using the azoles as a way to use lower doses of venetoclax. That's a pretty good strategy. Australia, they do that a lot because azoles are much cheaper than venetoclax and often covered by the nationalized health or more easily accessible. And so if you gave voriconazole and you could get it for a cheaper rate, you will then have to give 1/4 of venetoclax, which could be a cost benefit. So just something to think about, as a approach for our patients. So now moving to some of the targeted therapies, I'm going to talk about FLT3, IDH1, IDH2, NPM1, TP53, MLL. For all of these, there are targeted therapies either approved like FLT3 IDH or hopefully coming soon like menin inhibitors for the MLL NPM1 or CD47 antibodies for TP53. And this is great because just about 7 or 8 years ago, this whole slide did not exist. We had no targeted therapies approved. And today now we're thinking about 5 or 6 mutations that could have effective targeted therapy. So definitely things are moving. Of these, FLT3 is probably the most established and impactful. As you know, we have 2 FLT3 inhibitors already approved, midostaurin in the frontline setting with intensive chemotherapy based on the RATIFY phase 3, and gilteritinib as a single agent in the relapse refractory setting based on the Admiral study. It's very important to know what FLT3 inhibitor you're using for what FLT3 mutation. Again, for residents and fellows in the room, they are not all the same. You cannot just use any FLT3 inhibitor. There are certain FLT3 inhibitors that cover both ITD and TKD. These are the so-called type 1 inhibitors like gilteritinib, midostaurin. And there are certain FLT3 inhibitors that only hit the ITD. These are called type 2 like quizartinib. One does not make one better than the other because quizartinib is the most potent drug for ITD per se. So if you know there's an ITD, it's totally reasonable and good even to use quizartinib. But if there's a TKD, you don't want to use quizartinib because it's not going to work. Whether it's a TKD alone or an ITD with a TKD, you still would not, I would not use quizartinib. I would go to gilteritinib. So it's important to know that. And also, often if you have an ITD alone, you start with a drug like quizartinib, sorafenib with chemo or with HMA. At relapse, you will find 30 to 40% have a new emergent TKD. And so then you could switch to gilteritinib. So this is very similar to the CML, where you use the mutation profiling at progression to select the next TKI. And this way you could sequence patients with clinical benefit each time. So kind of important to know about that. This is RATIFY phase 3. I'm not going to go through this in detail. You all know the data. Really, the 2 key points here is FLT3 inhibitor alone is not going to improve outcome. It helps, but FLT3 inhibitor in first treatment with remission and transplant, if you do all of that, the so-called total therapy approach for AML, just like myeloma has their total therapy approach, then you can really start thinking of 60, 70% long-term survival. And that's quite great because just about 2 decades ago when FLT3 was first identified and shown to be prognostically adverse, the 4-year survival was 25%. So with the appropriate steps, we can now get to 60%, 65%, which is why FLT3 has moved from the adverse group where it was with a 20% survival 2 decades ago to the intermediate where it's about 60%. And maybe in the future, I think with maintenance and better FLT3 inhibitors, we could get into the 75, 80%, which would then put it into the favorable. And maybe one of the steps for that is the quizartinib. So quizartinib, very powerful FLT3 inhibitor, preclinically actually is the most powerful FLT3 inhibitor. If you look at the studies from 10, 12 years ago that were published by the groups in NIH and Nature. And here you see the randomized study eventually that occurred, which is a frontline study of 3+7 with quizartinib versus 3+7 placebo. This was in patients of all ages from 18 to 75 years of age who are considered to be suitable for intensive chemotherapy, and only for those who had a ITD positive mutation. This was the endpoint. So nice separation of the curves. You see overall survival benefit, median of 32 versus 16 and a half months. And there was about a 10, 11% absolute survival benefit at 3 years. So that's reasonable. And it does show a clinical benefit and improvement. And this should lead to the full approval of quizartinib. It's currently under the FDA committee review in the US, as well as in the EMA review in Europe. Again, here showing that quizartinib alone is not going to completely change the landscape of treatment. But if you identify FLT3, you add quizartinib or FLT3 inhibitor, and you take your patient to transplant, you do all of those things, which you should be doing anyways for all of our FLT3 ITD mutated patients. That should be the treatment logistic setup. Then you can start hoping for 3-year survivals of 70, 75%. That's the top blue line, quizartinib with allotransplant in CR1. On the other hand, if you are not using quizartinib and go to allotransplant in CR1, you can still do okay, but now we're looking at around 60%. So there's about a 10, 15% addition from the FLT3 inhibitor. The worst is, though, to not progressively adding benefit, and the more interventions you can incorporate in your treatment schema, the better the eventual outcome. What about those who could not go to transplant? So on the left, you see those who go to transplant. That's, of course, where we want our patients to be, whether it's with quizartinib or without. That's the way to go. With quizartinib, even better, close to 75, 80%. Without, it's about 60, 65%. But if you don't go to transplant, yes, both groups don't do as well. But it was nice to see that even then, the use of quizartinib still continues to show a benefit. So we know that in spite of all our best efforts, for many reasons, financial, logistical, distance from transplant center, non-availability of donor, non-suitability for transplant after induction due to major infections and comorbidities, people may go to transplant. But if you started them on the FLT3 inhibitor, you still don't feel bad because they're still going to have that benefit. There's still that nice 10, 15% difference between the curves. So even if they don't go to transplant, you did the right thing by starting the FLT3 inhibitor. If they go to transplant, even better. So what about some of the updates from ASH? So one of them is heavily on molecular data, and you'll see a lot of this coming out, and I won't spend too much time on this because I think this paper and others are going to come out, and maybe by next year, there'll be much more discussed. But the bottom line is this is one of the first studies, and many, many studies in the future will continue to now look at molecular and flow-based MRD. What they showed was that using a 10⁻⁻⁴, which is the established ELN MRD guideline, as well as the FDA recommended guideline, we see that about 50% of the patients achieved a molecular clearance. When you look at complete molecular clearance, which is less than 10⁻⁵, which is the sensitivity of this assay, then we see the numbers are smaller, but clearly quizartinib helped there, 22% versus 11%, so double the CMR rate. But you may not need CMR, 10⁻⁴ may be enough, is what this presentation showed. There wasn't a big survival difference in below 10⁻⁴ and CMR in the setting, probably because a lot of patients went to transplant. What they did show was that regardless of whether you got quizartinib or not, achieving MRD negative, here defined at less than 10⁻⁴ per the FDA ELN guidelines, was associated with improved survival. We all knew that. We all guessed that. It's always good to see that in a prospective randomized study, that MRD does carry very important prognostic value. But to me, this is a very important slide, and I think this may also lead into some of the data we will hopefully see later this year from the Morpho maintenance study. So here you see patients who had pre-transplant MRD negative, went on to transplant, and then either got quizartinib maintenance or placebo maintenance post-transplant. And what you see is if you achieved MRD negative, this was again defined as 10 raised to minus 4, was called MRD negative by molecular assay, there was very little benefit to quizartinib maintenance. So if you had an optimal response, achieve less than 10 raised to minus 4 pre-transplant, maintenance may or may not help. Now, remember, these are all subsets. Look at the numbers. These are smaller numbers, 54, 42. So this is not powered for that, but it's giving you a signal of what we may see from larger studies powered for post-transplant maintenance. On the other hand, if you're MRD positive, more than 10 raised to minus 4 detectable on a molecular assay pre-transplant, clearly then the addition of a maintenance with FLT3 inhibitor does add even to the transplant. Here you now start seeing that 20% benefit that we have seen with maintenance post-transplant. So this is one of the first studies to show that the MRD pre-transplant may help us select, again, this study was not powered for that, but may help us select patients who are most likely to benefit from maintenance and those where it may have little benefit and of course always has some toxicity and cost associated with it. So these were the studies that led to the full maintenance use of sorafenib or other FLT3 inhibitors. So this was the SORMAINS study where they used sorafenib versus observation post-transplant. Now, again, in this study, they did not have pre-transplant molecular FLT3 MRD, so we don't know that data like we did from the previous study from the Quantum First, but they did show that there was a benefit to maintenance. And another study from China published Lancet Oncology around the same time showed this. So this has led to us using maintenance quite frequently in all our patients with FLT3 mutated AML going to transplant. However, as many of you may have seen, or if you haven't, then I'll tell you just about a week ago, there was a press release showing that the large phase 3 randomized international study called the MORPHO study, which was actually designed to try and conclusively answer this question of maintenance post-transplant, all we know is all that is publicly known is the press release did not meet its primary endpoint. Without giving much data, because obviously I cannot talk about it, data is embargoed, I don't think that that is the right answer from this study. I think we have to wait to see the data, because when you see it, you will realize that this is not really a negative study. A lot of the devil is in the details, as they say. And I still think that there will be particular patients where we will want to continue to use maintenance, and there will be some where you may not. So there is a lot that we will learn from this study, but I do not think the cat is out of the bag, so to say. So I think we should wait and actually see the data before we make decisions. I like this slide. I think for fellows and others, there's a lot of data we're presenting, so it's hard to kind of synthesize this. So this shows the change in the FLT3 treatment landscape over the last just 10 years. This is not ancient history. So we first started seeing that the addition of high-dose daunorubicin benefited. This was shown by Alan Burnett, MRC group, especially in FLT3. Then the Polish group, Holowicki et al., showed the use of cladribine, purine analog, added to cytarabine anthracycline, had a benefit, especially in the FLT3 ITD positive. You see that curve, FLT3 ITD positive treated with DAC do much better than those who were treated with DA alone. So we started incorporating cladribine to our regimen in general, but especially for FLT3, we felt there could be even more benefit. Transplant, this was published by Schlenk, New England Journal, showed that there was a benefit for transplant. So then we were doing cladribine, idarubicin, Ara-C with transplant. Then sorafenib came along around 2010-11, so we started using sorafenib. So then we got to CLIA sorafenib, our regimen, incorporating cladribine from the Polish, using the sorafenib, and then doing allogeneic stem cell transplant. This now has moved to the second generation FLT3 inhibitors, where we're using quizartinib or gilteritinib, because they are much better, both single agent, preclinically and clinically. So now we're at CLIA, quizartinib or gilteritinib with allotransplant. And then the last piece of the puzzle here is coming in with the transplant maintenance after transplant, where we are using that today. And the MORPHO study, once it's published and presented, will give us more data on how best to use that. So this is kind of the sequence of how at Anderson we are now using CLIA, gilteritinib, transplant, post-transplant maintenance based on these multiple data sets over the last few years. And we will be updating our data, and we really are seeing now about 75% 5-year survival in our FLT3. So not as good as core binding factor, but actually it's getting there. So I really think in the next decade, FLT3 could become a favorable group. What about using FLT3, HMA-VEN and FLT3 mutated? This is some of the data here. It shows that, yes, you can get responses with HMA-VEN and FLT3, 67, 70%, but the survival is not going to be that good. It's only 11 months, so it's not even really that much better than AZA. So A lot of people, even in the US, where there's access, still want to give HMA-VEN to FLT3 mutated. I personally feel that that is not sufficient therapy. I mean, 11 months versus 8 months is really not where we want to be. Now, the TKDs, yes, they do seem to do decently well. You can get to 20 months. There's a plateau there. So maybe for TKD, HMA-VEN, okay. But for ITD, we decided at Anderson that this was not sufficient. We needed to do more. Now, at the same time, there was data showing that FLT3 inhibitors synergize very potently with venetoclax. So many drugs synergize with venetoclax, but in fact, the three that have shown to be most potent preclinical synergy are the FLT3 inhibitors, the BCR-ABL inhibitors, ponatinib, dasatinib, and the JAK inhibitors. And all three of these are in various phase 2, phase 3 development because the clinical data did confirm the preclinical signals. The other nice thing is that FLT3 also suppresses MCL1, which in fact now has been established as the major escape pathway to BCL2 venetoclax inhibition. So there could be a secondary benefit other than direct FLT3 targeting. That is why we're seeing this synergistic activity. So we started looking at the combination regimens of aza-ven with a FLT3 inhibitor, either sorafenib or midostaurin, commercially available about 4 years ago. We had a non-trial experience here of about 30 patients treated with HMA-ven with the FLT3 inhibitor versus our HMA-ven or HMA-FLT3 experience over the last 7-8 years. And what we're seeing is that the 3-drug combination, whether it's for CR/CRi, whether it's for CR or for MRD negative, and even for survival, is looking encouraging. Again, this is a retrospective analysis. All of these patients were not on trials, so this is not a gold standard bona fide, but it's definitely giving you the signal that within MD Anderson, same group of people treating patients, similar patient profile, the addition of a FLT3 inhibitor seems to be adding that extra punch for response and OS. Now, what's really important here is, again, the duration. You cannot give more than 14 days of venetoclax absolutely when you're adding a FLT3 inhibitor. So we came to this over multiple iterations over the last few years. We tried 21 days, was too much. We went to 14 days of ven, was okay. But even then, the FLT3 inhibitor continuous was too much. So now we're doing 14 days of ven, and we have cut the FLT3 inhibitor at 14 days. With 14 of both, the regimen is now really, really well tolerated. So 21 and 28 was what we started with, and now it's 14. And we had to do this to work with the FDA because they were not comfortable with off-label reduction. But now with the data being generated and us showing it to them, they are now getting more and more comfortable that 14 days is enough, and more than 14 days may actually be dangerous. So just as I know many people use this, it's important to note it's 14 and 14 of both, and you stop on day 14. We usually do a day marrow on day 14 to confirm response. So this has now led to prospective study, which was presented at ASH. This was probably one of the big highlights from ASH. Single arm study has to be confirmed. A larger phase 2 study in the US has started, led by Dr. Altman and me across 30 centers that will hopefully confirm this initial experience that we had from MD Anderson. But it's hard to argue with this. These were older, unfit. All of the patients were above 65 years of age. Response rate is 100%. Not only is the response rate 100%, many people say, oh, there's myelosuppression, but actually the CR rate is 92%. So that was full count recovery, platelet above 100, ANC above 1, and the early mortality is 0. The salvage experience is good, but not as great. But the frontline, I think this really is where we're going to end up for FLT3 mutated older unfit AML. And many people are saying, looking at this data again at that meeting in Munich, why older? Why should I not give this to my 50-year-old, 55-year-old? I think we need to wait. Let's get more mature data. And then I think this would be a good randomized study. Aza-ven, gilteritinib versus intensive chemo, FLT3 inhibitor, whatever you want, MIDE or quiz. That is a study where there is therapeutic equipoise. I would really like to know the answer to that study. Could the triplet, low intensity, be equal or beat high intensity chemo? Survival here looks good, but again, 1 year follow-up. At 2 years, if we continue to see greater than 60, 65%, I think then there's a real question that maybe intensive chemo could be replaced, and such a randomized study would be very interesting. A lot of people are worried about count recovery, and indeed, if you're using 21 days of ven or more than 14 days of FLT3 inhibitor, it used to be a problem. With the current regimen, about 35 days count recovery. In fact, that's exactly the same with HMA-ven. 34 days was the count recovery published by Keith Pratt. So now we are actually at the same count recovery period of HMA-ven with a much better response. I'm going to skip IDH. Many of you have heard of the Agile data, but it's not available in India, so it's not that important. TP53, this is where immunotherapies are being heavily used. I want to show this data from ASH. This was from Donor. We often use the ELN, again, a little bit blindly across all therapeutic groups. The ELN was developed for intensive chemotherapy only, ELN 2017-22. When you apply the ELN to HMA-VEN patients, it does not discriminate well. This was shown in I'm not showing you the whole presentation, they showed that. And in fact, in the older unfit above 70, 65% of the patients by default are ELN adverse, because we know they all have TP53, they all have deletion 5, 7, secondary AML, etc. So then they defined a new analysis using 400 patients from the HMA-VEN VIALE study and showed that what really prognosticated was 3 mutations. TP53 mutation, if you have it, worst of the worst. HMA-VEN, maybe not even better than HMA alone, survival of 6 months or less. So this group needs something new. TP53 wild type, but signaling mutation, either FLT3 or RAS. Middle group, 12 months, okay, but needs to be improved. This is where we're adding FLT3 inhibitors, or for the RAS, we're starting to add pure analogs. Based on recent data, pure analogs may work very well for RAS-mutated AML. And then the third group, no TP53, no signaling FLT3 or RAS, that's the group that does the best, 26-month median survival. Now, 26 months is good, but could be better. So even there, for IDH mutated or NPM1 mutated, we're going to try to add IDH inhibitors or menin inhibitors. For the TP53, a lot of excitement and work ongoing in the CD47 space. We're leading a lot of these efforts. This seems to be a major new immune checkpoint for macrophages, may have applicability in AML, lymphoma, but maybe even beyond that in solid tumors. But right now, the focus is on myeloid diseases. This was data we presented at the EHA meeting, was not at ASH, but was presented at EHA, where we showed that this combination is giving you good response rate, about 50%. HMA-VEN gives you about 40% here. And importantly, the true CR rate of about 34%. HMA-VEN, the true CR rate in TP53 is 19%. This was just published by Dan Polier and colleagues in clinical cancer research. So we do think there's a gradient there with improved responses, not a blockbuster. We're not at 80, 90%, but any progress is good, especially for TP53. And we think that these data will hopefully lead to a approval based on an ongoing registration study. We have to wait for that data. Median survival 11 months. With HMA-VEN, it's been 5 to 6 months, as I just showed you. And with transplant, you can improve that. So there's a phase 3 study ongoing looking at HMA-Magro versus HMA-VEN in TP53 mutated AML called the Enhanced 2 study. And that data will hopefully be available next year. If positive, could be the first TP53 molecular-directed therapy approved in the frontline setting. And then, of course, we have to improve on it further, because 11 months is okay, but not great. And then we can add other agents or sequence depending on other emerging therapies. Also, approaches to combine AZA-VEN with Magro. If AZA-Magro is good, could you also still incorporate VEN? Preclinical data from Marina Konopleva suggests yes, that there was an additional synergistic benefit, increased macrophage activity with the venetoclax and HMA versus just HMA when added to the magrolimab. And so this has led to our triple regimen here. Again, similar to the HMA-VEN FLT3 here, we're doing HMA-VEN CD47. TP53 is kind of the target population. And again, single arm study, but if this is true, CR/CR of 64% with the CR 46%, this is basically double of what you get with HMA-VEN. The CR/CR rate there was 40%, and the CR rate was 19%. So again, this has to be confirmed, and this has led to another ongoing randomized phase 3 study. We also did propensity analysis, again, within MD Anderson frontline clinical trial patients. And here it did appear that in the TP53, the HMA-VEN Magro is giving a benefit both for response and overall survival of 11 months versus about 4 months with HMA-VEN. So this was now leading to 2 randomized phase 3 studies going on across the globe. One of them with HMA-Magro versus HMA-VEN. The other is HMA-VEN Magro versus HMA-VEN placebo for all comers, not just TP53. So can you improve your general low-intensity frontline therapy for older unfit AML with the triple therapy? And then the other one is more TP50 specific. So we're excited and eager to hear these data. And this could be one of the first immunotherapies, really. As I mentioned, there are no immunotherapies approved in AML. So this could be the first immunotherapy per se that could be approved. So that would be a nice addition. The last group I'll talk about, last couple of slides, menin inhibitors. So this is another major blockbuster that we think is coming. the fourth targeted therapy after FLT3, IDH1, IDH2. This targets a group of MLL rearranged and NPM1 mutated. These make about 10 to 15% of relapsed AML. Also, a very important group in pediatric, both relapsed AML and ALL, where up to 70% of patients with relapsed pediatric AML could have this MLL rearrangement, and also in pediatric ALL, it can be 5 to 10%. So this study actually is one of the first studies that allowed, even in the phase 1 enrollment of children pediatric groups, we pushed very hard with the FDA to allow that, and we're very happy that happened, because we at MD Anderson treat about 15 children, and many of them have had an outstanding response after failing 3 or 4 lines of standard therapy and are alive now a few years later. So that was very, very gratifying, and we're happy that the FDA allowed us to allow the children on the study. So here you see the response data from the study that was presented. There are 2 of them ongoing. I'll focus on the Syndax because that's the one that had more patients and is more ahead. This was presented by Gus Issa from MD Anderson, and we enrolled a lot of these patients. And we find that as a single agent in the relapse setting, this is giving us 50% response rate. Now, this may not look that good, but you have to know that this was a median of 4 salvage patients. So these are patients we would be sending to hospice 99% of the time in the past. MLL rearranged 4th salvage. And in that group, to get a 50% response rate with a 30% true CR/CRh count recovery is really quite fantastic. So we're very excited about these data. It seems to work both in MLL and NPM1, although the signal is a little bit stronger in MLL. A lot of discussion about the biology and trying to understand why that's happening. That's probably a separate lecture on its own in the future. And there are many menin inhibitors. 2 of them presented at ASH, the Syndax and Kura, the top 2. But we're also working with J&J, with Sumitomo, with Daiichi, and in fact, there's another one recently. And without going into details, we are seeing big differences in the kinetics of responses, the differentiation syndrome, the toxicities, as well as the neutropenia signal. So I think just like FLT3, there will eventually be more than 1 menin inhibitor, maybe 2 or 3 used in different settings, in different combinations, in different patient profiles based on underlying comorbidities and tolerability. Last thing is immunotherapy. You noticed I didn't talk much because there is unfortunately not much to talk about yet in cellular therapies in AML. There's a huge effort ongoing. This is probably the next big shot in the next 3 to 4 years. In fact, I personally am involved a lot in developing cellular therapies in AML. That's probably my big focus now for the next few years. Sargil and Marian Suklevi and others are working on this as well with us. So it's a matter of time. It's not going to be singular targeting. There's no ideal target in AML, but there are other approaches using double, triple targeting, gated CAR T cells, and or gating, a lot of things that are ongoing that will hopefully get us eventually cellular therapies in AML. I think it's a matter of when, not if, and we will get there, but in a few years, ideally. So far, the data with the single UniCAR targeting has been modest, and I think a lot of these are transitioning into dual or triple or sequential cellular therapies, as well as potentially NK cell based therapies. So this is a new area that we should keep our eyes open. I think this coming ASH and the next ASH, you'll start seeing more and more cell therapy data in the future. So all in all, I think a lot is happening. I think the key thing here is molecular stratification of therapy is critical. We can no longer apply 7+3 or HMA blindly. You definitely need to know FLT3. I would argue you need to know core binding factor and APL. I would even say that it's important to probably know the status of TP53. Those patients do not benefit from intensive chemo. One could do HMA alone or HMA-ven. Maybe in the future, the CD47 and magrolimab story will lead to that being used. We have to wait for the randomized study. And even in older AML, 23% 4-year survival with HMA-ven. Better than HMA, but that's not great. So here, the FLT3 addition is showing clear efficacy, all parameters improved, good tolerability, and we have kind of moved with that as our standard approach, but also potentially adding IDH efforts are looking at that and showing good signal. And then there are also efforts adding CD47 to the HMA-ven across the board for TP53 and high risk. So I think you will see evolution of the HMA-ven towards either a triplet or sequential approaches in the near future. So with that, I will stop and happy to take some questions.
Thank you, Dr. Naval, for a wonderful lecture. What a super fantastic and update on AML. and always good to listen to you as always. And every time when we listen to it, so something new things we learn from you. Well, thank you so much for joining us. So we have some Indian colleagues who will interact with you now. I request all our discussions to please put the raise in signs. In the meanwhile, I will start from the audience. Dr. AKM Mainul has a question that she has a 34 years woman, AML, with good cytidines. Got cytarabine plus donomycin 3+7 induction with sorafenib, not in remission. Next got again 3+5+5 with sorafenib, still partial remission. Now what will be the approach? Ven plus EZA or 2 to 4 cycles, then for 2 to 4 cycles Ven plus EZA and then LOBMT. So what would be the approach?
Yeah, I would actually do aza-ven sorafenib in this patient. She's obviously young. She's fit. She was able to tolerate 3+7 sorafenib. Aza-ven sorafenib is much easier to tolerate than that. So I would do aza 7 days, 75 per meter square for 7 days. I would do ven. You could do 10 or 14 days. You know, I know in India, even the 14, 21 days is hard. I've been talking to colleagues. So maybe you do 10 or 14 days of ven. And then I would do sorafenib, maybe 200 BID for 14 days. This will give you about an 80% response rate based on our experience using this 3-drug combination. And then you move directly to transplant by day 28 to 35 once you've achieved marrow clearance. That's what I would do here. Yeah.
Thank you, Dr. Naval. Another question from Dr. Kunal Chatani. He has a 63 years AML patient on azacitidine and venetoclax. He has planned maintenance with oral azacitidine. So what is the maximum duration of venetoclax and IV azacitidine before switching to oral AZA maintenance?
It's a great question. So the answer is I don't know. Nobody knows. You know, you have to remember the oral AZA study was done in the setting of intensive chemotherapy. There were no HMA-VEN, although I know the label in the US and many countries is saying post-induction and people are extrapolating the induction to include HMA-VEN. So the simple answer is I don't know. I'm a bit nervous about, in fact, this is something we discussed at some of the meetings recently as well, about this approach because the oral AZA only gives you about 35% PK equivalence of IV AZA. So you're giving 1/3 the dose of AZA and omitting the VEN, right? So it's a little bit risky because the patient could relapse. Now, that being said, I think if you've given about a year of HMA-VEN, and ideally if you have some kind of molecular flow marker that makes you feel confident that you've achieved a deeper level of response than just CR/CRi MRD clearance, I think it could be reasonable. What I would do, what we're doing at MD Anderson is we prefer to keep both HMA-VEN. Remember, VEN alone didn't do much and HMA alone doesn't do much as the combo. So we prefer to keep both at attenuated schedules. So I have many patients who are getting 5 HMA, 5 VEN, 5 and 5, or 7 and 7, but I prefer to keep them on HMA-VEN even for 5 or 7 days together every 4 to 5 weeks rather than omit one. So that is what I would think about, do 7-7 or 5-7 and then do the cycles every 5-6 weeks. So the patient is still not spending too much time, but getting both. If one had to switch, then after a year, if you've confirmed MRD clearance, one could try the oral AZA, but it's just something that really there's very limited data on.
Thank you. Another question from Dr. Vinayak Chikodi. He has asked that are 20% blast or more than 20% blast still necessary for diagnosis of AML in peripheral blood?
Yeah, so you might have noticed I purposely stayed away from the whole ICC, WHO. Yesterday when the meeting, there was a lot of discussion on this. So my answer is no, actually no. So one thing that they both agree on, the WHO and ICC, and we all agree on actually, is we were very involved in part of both of these through MD Anderson, is that the molecular markers or the fusions are really what drive the disease biology, the outcome, and the treatment. And I think 10 years from now, this whole differentiation of AML MDS is probably going to be gone. It's going to be MLL rearranged myeloid disease, TP53 myeloid disease. So there's about 8 different aberrations that clearly define, you can call it AML or MDS, doesn't matter. It clearly defines an entity that has unique treatment. PML RAR, inversion 16, 821. So these have unique therapy, doesn't matter, blaster, 8%, 18%, 48%. You treat them as that entity. The next one is MLL, inversion 3Q. These are also in that group. And now there's also a group of fusions, the NUP98, the NUP24 fusions that are going into that group. And even probably the most important ones are NPM1, CBP, and FLT3. So if you have these, even with low blast, these patients should be treated. And in fact, for NPM1, if we have an NPM1 with 8, 10, 12, 14% blast, we are giving them intensive chemotherapy. We're treating them like AML. Same for FLT3. So the answer is it should be based on the molecular cytogenetics. I don't care if the blasts are 18% today and 22% tomorrow. We all know that doesn't really impact your biology. So, yeah.
Thanks a lot. Another question from Dr. Negasa. He has an AML patient given induction therapy. After induction therapy, the patient has 55% blast in the bone marrow aspirate. Shall we continue with consolidation or go for other options?
Yeah, it's a tough one. I mean, a lot of this gets into details of what your induction was. You know, if it was like a 3+7, then we probably would do flag ida ven here. If you already use something like a flag ida, then the flag ida ven, the chances of response are low. So flag ida ven is what we have done for a lot of patients coming to us after 3+7 failure. The second option would be if you've already given a purine analog containing induction like flag ida or CLIA, then HMA ven has about a 40-45% response in this setting and could go to transplant. And of course, this all assumes that we have ruled out FLT3 and targetable mutations.
Thank you. Dr. Gopinathan has a question. He has a 36 years old fit male patient with inversion 16. So in a resource limited setting like India, 3+7 versus HMA ven.
Yeah, this is the one group where I would be very, very nervous to go to HMA ven, right? If I had, in the future, I predict that almost all intermediate adverse will get on some form of HMA ven backbone, probably with a third targeted agent or immune agent added. But I think the group where this will happen last, and we need data, is APL core binding factor and isolated NPM1. So the simple answer today is no. We have not treated a single patient, and nobody in the US would recommend this. 3+7 is still cheap. I mean, it's cheaper than HMA ven. So if I'd had to, I would give 3+7 and then transplant if that's needed.
Thank you. Dr. Aditya, your question, please.
Thank you, Dr. Naval, for the fantastic talk. So my question is regarding the AML patients with extramedullary disease, the myeloid sarcomas. So what has been your experience while treating with HMA ven in such kind of patients? How does the extramedullary disease
Yeah, it's a
respond?
great question. Yeah. So yeah, we were worried about this quite a bit, that it will not have as much extramedullary activity. But in fact, we are seeing it's pretty good even for extramedullary disease. And actually, there's data coming from BPDCN where venetoclax has been used, and almost 80% of that disease is extramedullary. And it's shown to be very, very effective. Paper in Cancer Discovery by Naveen Pemraju, Andy Lane, Marina Konopleva. So VEN seems to have good extramedullary activity. If our choice is to do HMA ven based on fitness and prior therapies, and if they have extramedullary disease, we still go with it. It doesn't change our decision.
And I would like to ask you, what is your go-to regimen or sequencing in patients who present with hyperleukocytosis?
Patients with hyperleukocytosis?
Yeah.
Yeah, I mean, the regimen doesn't change much for us. It really depends on what their molecular profile is, right? So initially we have to cool them down. So we admit them, we often do cytarabine, hydrea, very rare cases, but sometimes the white count is above 200 or they're having signs of leukostasis, pulmonary edema, ocular neurological issues. We may do a leukapheresis. What then we really do the treatment is often based on their molecular profile. A lot of these, as you know, will be FLT3 mutated. So then they will go on frontline clear-gilteritinib is our frontline treatment, or clear-quizartinib. We have both of those ongoing. If they happen to have an MLL, then it's usually intensive chemo then. So we usually don't rush to start the chemo, the whole regimen. We cool them down with cytarabine, 500 to 1 gram daily, couple of days, hydrea, 5 to 6 grams daily, couple of days, if needed, leukapheresis. And by day 4 or so, they're down to below 30, 20. And that's when we will start the frontline regimen. So it doesn't change our frontline selection. That's still based on molecular and cytogenetics. Yeah.
Thank you.
Thank you, Dr. Aditya. Dr. Shyam has a question. Is triplet regimen VEN plus EZA plus FLT3 better than doublet EZA plus FLT3? So FLT3 AML.
Yeah, so my answer is absolutely. I mean, again, this will require or may not require, as I said, randomized study. It may be a very hard randomized study to do when you see these numbers and data. Again, I think the therapeutic equipoise is already established. So there is a larger single arm study, about 100 patients, that's going to do AZA-VEN guilt, and that's going to include about 30 centers. So, broader than just MD Anderson experience. But I think once that confirms what we have seen, which I think it will, I think the HMA-VEN FLT3 will become established as a frontline regimen. The CR/CRI, the CR, the MRD negativity, and the survival are all looking better. The second question that I see also, I think is a good question, right? I think versus HMA-VEN, to me already, and we've been doing this for 2.5, 3 years, to us, the jury's out. Yes, HMA-VEN FLT3 is clearly better than HMA-VEN. Is it better than intensive chemo? I don't know. So that is the trial I would do. And in fact, the MRC group, as well as the German SAL group, both have approached us and are looking at doing such a trial, HMA-VEN guilt versus intensive chemo, MIDO, or intensive chemo quiz. And that will be a very interesting trial, because if positive, could in fact lead to a lower intensity triplet across the board for FLT3 in the next 5 years. So that'll be very cool to see.
Thank you, Dr. Noble. Another question from Dr. Shyam. Does venetoclax have efficacy in TP53 AML?
The simple answer is probably no. But there's always nuances, right? If I have a 50-year-old and I have a sibling donor transplant ready, HMA-VEN does give you a higher response rate and a quicker response rate. So we have this debate in our group. So if it's a young patient, transplant is a goal, you want to get them into a marrow remission/ablation, HMA-VEN will get you there in 1 or 2 cycles. HMA will take 4 to 6 cycles. We will do HMA-VEN, go to transplant. If you have a 74-year-old, 75-year-old, and you're not going to take them to transplant, HMA-VEN will give you more myelosuppression with a similar survival, 5.5, 6 months. So then we actually are doing HMA alone, decitabine 10 days, or even AZA standard. So that's kind of where we're at this time. The bottom line is we need something different for VEN for TP53 in the future.
Thank you. Dr. Dibyendu, your question, please.
Hi. First of all, very good lecture actually, and we have learned a lot of things right now today. I have 2 questions actually. One, some of the patients present with intraneural chloroma, or like intradural soft tissue chloroma. In these patients, whether venetoclax have a good results. And secondly, in some of the older patients where the cytopenia is really a problem, where we are using azacitidine plus venetoclax, can we go for azacitidine at a lower dose for a long durations, like 50 milligram per square meter for 10 days or 14 days, like that? Is there regimens like that?
Yeah, so the first question, I don't know. CNS penetration of venetoclax is what we're asking. I do not know the answer to that. We have not depended on venetoclax for CNS penetration. If we see any CNS lesion, whether it's cerebrospinal fluid positivity or a chloroma or intradural or subdural mass, we usually just treat them with intrathecal chemo and or radiation, as you would for a isolated CNS disease. The venetoclax covers a systemic disease. It's a great question, probably something we should look at to see whether there is CSF penetration of venetoclax. The second question is, I think less venetoclax is the key. And each country and each region has to tailor this and do the studies to really identify what is optimal. I would say that 14 days of VEN is probably sufficient in most regions, maybe even less in some. As I said, the French, it's a good abstract to look up. Stéphane de Botton, they looked at what they called 7-7, AZA 7, VEN 7, given from day 1 through 7, and they showed 63% CR/CRI. 68 was what we saw with VIALE-A. So they used much less, and it was effective. I don't know about the AZA dosing. I don't think the AZA is the problem, because when you look at the AZA arm, even on the AZA-VEN, that did pretty well. Very few people needed growth factor. Very few people had prolonged neutropenia, myelosuppression. So I think usually we're okay with AZA. One could do 5 days or 7 days, reduce it. And then the VEN, I think 14 days. So maybe 5 days of AZA, 14 days of VEN is probably a good starting point. And once you achieve remission, dropping the VEN down to 10 or 7 days for subsequent cycles should avoid severe myelosuppression. Yeah.
Thank you.
Thank you, Dr. Dibyendu. One question from Dr. Kunal Chatani. He has asked, what is the minimum dose of HIDAC in consolidation? Patient is obtained CR after 7+3, and patient not tolerating 3 gram per meter square of HIDAC due to prolonged febrile neutropenia.
Yeah, I think the 3 gram per meter squared is just a overkill. It's too much, and as you know from a lot of the emerging data, many centers in the US are not doing that for above 60, even above 50. So I think 1.5 per meter square is reasonable to do that twice a day for day 1, 3, and 5. Or if you're uncomfortable, even 1 gram per meter square is reasonable. You know, the other option is you could do something like a fludarabine, cytarabine. There you could offset the Ara-C dose, go for like 1 gram or 750 per meter square cytarabine for days 1, 2, and 3, and use a low dose fludarabine along with that, like a 15 per meter square days 1, 2, and 3. And that's usually going to be less myelosuppressive than even 1.5. So that's what I would do.
Thank you. One question from Dr. Subranil. He has asked the role of FLT3 inhibitors in FLT3 non-mutated AML. And second question is decitabine versus EZA plus VEN. What should we give?
Yeah, so I think at this point the consensus answer is no for FLT3 inhibitors, non-FLT3 AML. Although, and as this is probably where Dr. Shubra is indicating, is that there have been data in the past with sorafenib called the SORAMEL study, where addition of sorafenib and non-FLT3 seemed to have a RFS benefit, never panned out in OS, and then also with quizartinib initially there was some activity, but I would not use it. I think if one had to incorporate a drug in non-FLT3 in the frontline setting, venetoclax or gemtuzumab is in the appropriate setting is good. Decitabine versus AZA does not matter. They're both equal. The data is very equal. AZA was just chosen because it had a regulatory path already being approved in Europe in the past. Decitabine did not have a full label, but you could use either one.
Thank you. Dr. Alka, your question, please.
Can you hear me?
Yeah, please go ahead.
Thank you, Dr. Dawa, for such an interesting talk and very inciting data. The thing is, I was very intrigued by the approach of dosing of venetoclax with use of azoles. So, because in AMLs we use posaconazole, voriconazole, or isavuconazole, but you also said use of fluconazole. So, usually fluconazole is not being used as a prophylaxis, but because it will be cheaper. So I just wanted to know about the use of fluconazole for venetoclax dosing in our setup.
Right, just a good point you bring up. So I would not recommend using fluconazole, right? It is done, and that's why I mentioned if you use it, you have to dose adjust. But I totally agree that it's not a effective mold aspergillus coverage. So I would prefer voriconazole, posaconazole, or isavuconazole. Yes, those are the ideal ones. But sometimes because of cost, other things, people have to use it. Then it's a second choice if you have to. Yeah.
Another simple question. This was regarding your initial slides on APML. So I just want to know, how do you diagnose CNS disease in APML at presentation? Because they may be having CNS symptoms because of bleed or infarct. So how do you diagnose and how do you manage CNS disease in APML?
Yeah, so we don't routinely look for CNS disease in APML. We only do it in patients who come in with signs of intracranial hemorrhage, subdural hemorrhage, subarachnoid, because there's a compromise of the blood-brain barrier. So in those patients, we would do a diagnostic plus prophylactic intrathecal chemotherapy. If it was negative, we usually plan to do 2 to 3 prophylactics, and that's it. If they're positive, of course, then we do the full treatment, weekly till they're negative, then monthly for 12 months. But those who don't come with CNS bleed or any severe leukocytosis, then we don't normally do a diagnostic LP for all our patients. We don't do it. Yeah.
Thank you.
Thank you, Dr. Alka. One question from Dr. Trivikram Panda. He wants to know, how do you risk stratify NPM mutated AML with abnormal genotype, which is not mentioned in favorable or adverse risk AML, like NPM with additional chromosome derivative of 16?
Yeah, so I mean, in general, if you have an adverse feature, then yes, that is what drives it. And then, you have like NPM1 with a splice mutation or ASXL1, then those are adverse. If it's non-defining, then technically it still falls in favorable. So if you have an NPM1 with something else that does not fall into intermediate adverse ELN, then we would still consider NPM1 as a driver. NPM1 is very tricky because a lot of people, I think, are moving away from transplant. And I think me and all of us at Anderson are nervous about that because a lot of that is predicated on having really good NPM1 PCR. So if you look at the recent data from Richard Dillon in the UK group, they have given really the most beautiful data of how you can use NPM1. If you have a 10 raised to minus 6, we don't even have that in Anderson, PCR like we do for ALL adaptive sequencing, and you can show negativity. So that is 10 in a million. Then the cure rate was 95%. But on the current flows and the current NPM1 PCRs, there's still a high relapse risk. So we are usually erring towards transplant unless it's truly isolated NPM1 and truly negative on 2 or 3 consecutive values. So I would just be a little bit careful for younger patients to not do transplant in NPM1 if they have a good donor.
Thank you. One question from Dr. Mirza Salim Amjad. He has asked that 45 years old male, AML, normal karyotype, FLT3 TKD mutation positive, given 3+7 induction with midostatin, post-induction day 28, not in remission. Now what to do?
Well, I mean, a lot of it depends on what is not in remission. I mean, if the blasts are coming down, then, often I would just wait another 10 days, repeat a marrow, we can see delayed remission, and then I would do a reinduction. If the patient is truly, no response, like 50%, and now it's still 50, 60%, okay, so real no response, then I think flag-ida ven is very good here. With the TKD, it's interesting. The ven seems to work quite well there. And even frontline, sometimes if we have a low TKD, we may still go with clear flag-ida ven because we think the ven is as good, maybe better than FLT3. ITD, that's not the case. So this could be a very good candidate for flag-ida ven done in the right setting with good monitoring.
Thank you. Another question. In a young fit AML, intermediate risk and no FLT3, low dose cytarabine plus venetoclax or versus EZA plus venetoclax? Any data to support this less intensive therapy?
And this is for a young patient?
Young fit patient.
Yeah, no data right now. I mean, there's an ongoing randomized study in the US looking at aza-ven versus 3+7 in 18 to 75 years of age. So we have to wait for that. But for today, I would not do it below 65 or 60 maybe, yeah.
Thank you. Another same question. In older AML, how long to continue ven plus EZA if in remission and MRD negative?
It's a great question. We do not know the answer to that. So we usually try to continue it as long as possible with much shorter durations, so 7 and 7 or so of aza-ven and then every 5-6 weeks. But we just keep going. There are some people who have NPM1 again, where if you can use a molecular assay and show that it's cleared, then you may be able to stop. But for the broad majority, we don't have a good molecular assay like that. So we just keep going with reduced aza-ven.
Thank you. Another repeat question from Dr. Gopinathan, 70 years old male with EZA-ven, induction given. Now please comment on reduction duration of ven to 7 days. Is it okay?
Yeah, I think, again, if you've achieved remission, I think 7 days is probably very reasonable, yes.
Another question from Dr. Tribikram Panda. What's your take on EZA-ven followed by high-deck consolidation in score binding positive leukemia, CBF leukemia?
Yeah, we don't know. We don't know because there's very little data of aza-ven in core binding. I personally would be very nervous and would not do aza-ven in core binding factor. I think that's a little bit too much of a stretch. I think that's the one group where 80% or higher survival can be achieved with traditional intensive chemo with or without transplant. So I would stick with that for now.
Thank you. Another question from Dr. Jaswanthini. In a 3-year-old child having AML with MLL gene rearrangement, what could be the preferred regimen before transplant? And can we go for any maintenance post-transplant?
Yeah, it's a great question. I mean, obviously, the menin inhibitors are what will eventually be interesting. And of course, it's a few years before they will become available. So here also actually ven works quite well. So if you look at the flag-ida ven paper, Courtney DiNardo's paper in JCO, there was a subset about 6-7 patients, MLL rearranged. In fact, the response rate was 100% with MRD clearance in almost all of them. So intensive chemo ven works really well in young patients or older patients. So that's what I would do, whether it's flag-ida ven, clear ven. Of course, you have to adjust pediatrician doses, but that should give you a good path to go to transplant, intensive chemo ven.
Thank you. Dr. Chiraksha has a question. What is the long-term outcome with transplant in TP53 positive AML?
Yeah, it really depends on how you go into transplant. A lot of data now showing that those who achieve a significant molecular or cytogenetic remission, non-detectable TP53 pre-transplant could have about 40% 2-year survival. But some of the data from our group and from Justin Loki published in Cancer from the group in the UK suggests that even in a remission with low-level detectable molecular TP53, there was about a 30%, 25-30% survival. So I think that's probably the number, about 30% or so, 2-3 year survival with transplant, which is much better than without transplant, where it's about 5 to 7 months.
Thank you. And a last question from Dr. Nishad Dakate, 25 years old female, AML, 8 translocation 822, given induction 7+3, followed by 3 cycles of consolidation. PCR for 821 is 0.02 at the end of three consolidation. And then after 3 it rose to 0.03. What would you do now?
Yeah, I think that's still very low, less than 0.1. So I would stick with the consolidations at this point. You know, this would be a really good patient if you could get access to do gemtuzumab. Even 1 or 2 doses added to the subsequent consolidations will very likely get this patient negative. If not, then, you know, I would do the 3 or 4 consolidations. We have actually used HMA and HMA-VEN as a maintenance in these patients. So I've had patients where we do 3, 4 consolidations. They have a low-level molecular. I'm not comfortable stopping, but I also don't feel like doing transplant. Then we usually do HMA-VEN 7/7, you know, for about 6 to 9 months. And if the molecular is cleared, you could stop and monitor then.
Thank you. Dr. Vishwadip, your question, please.
Hello, good morning, Dr. Naval. So a lot of questions popped up in my head while listening to the talk. So one thing is when we use magrolimab and TP53 mutated AML, like was there any percentage of people who are having biallelic mutation or deletion? And is there any like clearly worse response to that? And whether there is anything which can be used to stimulate dendritic cell attack on any malignancy while using magrolimab? That was one. I'll just ask another question later on, just after this one.
Yes, in fact, about 75% of those patients, as I recall in the papers and review to be out soon, were what we would call multi-hit TP53. You know, it's not necessarily biallelic, but multi-hit. So they either had a VAF greater than 50%, or they had a mutation plus a deletion 17p, or they had multiple TP53 mutations. So those are the ones that have, at least in MDS field, been associated with worse outcome. In AML, it's controversial because the data from GROB, et cetera, from the whole one suggested that it didn't matter that much in AML, whether you had a single hit or multi-hit, and the VAF did not have that much impact. But yeah, majority of these patients are what we would call multi-hit, and the response rate was similar. The survival was actually similar. So it doesn't seem to get impacted that much by the more TP53 driven diseases. The dendritic cell, I don't know. I mean, there are a lot of strategies we're looking at. There's radiation being combined with magrolimab. There's chemo, intensive chemo. There's other immune checkpoints, T cell checkpoints, pembrolizumab, ipilimumab. So a lot of that will come in the next few years. We'll just have to wait and see.
And I was wondering, like initial data with Geo showing response in good risk, that was mainly in the backbone with the backbone of chemotherapy, which effectively essentially doesn't work with TP53 as the primary driver mutation. So would trial of Geo in combination with magrolimab be like in thoughts somewhere, or at least they would discuss about it even if they reject it outrightly? One thing was that. Second thing, any other mechanism of apoptosis, like arsenic is supposed to have another TP53 independent mechanism of apoptosis. Would that be a good choice to add? And in ATO, I just wanted to ask another question. Like we give mostly a differentiating dose when we treat APML. So would it be like different in AML because we want to hit high, stronger, not like as in just to differentiate the promyelocytes into neutrophils, but we want to get the toxic effect of ATO to the cells, just like other chemotherapy. So would the can be the failure of ATO in AML can the reason be the wrong dose selection, like lower continuous dose rather than a higher shorter dose?
Yeah,
regimen.
I don't know. These are all great trial concepts, right? I mean, yeah, conceptually, sure. I think ATO would be great to combine with CD47, but I think that's a trial that has to be done. I think Geo with CD47 is not a bad idea, even for high risk, because I agree with you that most of that was in the context of intensive chemo. So I think that would be a good trial to try and conduct, hopefully when we have some approval pathways for magrolimab established. Yeah.
One patient related question. Uh, I had a patient who came to us with hyperleukostasis, 250,000 counts with around 30 to 40% blast in the peripheral blood only. We and MPO was dim positive on cytochemistry. There was a lot of necrosis and the marrow was all necrosed, and we could not even process flow because the sample we processed for flow had a lot of debris, so they could not get the abnormal cells classified, and like blast of myeloid or lymphoid lineage classified, but MPO on the cytochemistry was dim positive. Then with hydroxyurea in 2 3 days, by the time we got the flow report, a blast like total count came down from 250,000 to around 45 40,000. So at that time I sent again peripheral blood for flow. That time there were no abnormal cell in the peripheral blood, like 1% blast of myeloid lineage, and it's not like what we were expecting. And the molecular testing shows FIP1L1 PDGFR rearrangement. So I was wondering, like, right, he was very sick at that time. So with counts went low, so I stopped hydroxyurea, thinking that there is a lot of necrosis. So he is slowly recovering. His lungs have become better. Edema has come down. But I've started imatinib based on the FIP1L1, but I'm thinking it is mostly an underkill because he has documented evidence of myeloid leukemia. So would it be wrong to label him as AML with FIP1L1, or we can still label that? Like, have you seen remissions with just hydroxy? Not remission, but like
Yes.
set.
Yeah. Imatinib alone works very well, even in myeloid blast phase FLIP1 PDGFR. So if the patient is quite sick, I would actually just do imatinib for 2 3 weeks, stable, check the marrow, and then if he's not responding, you could add like an HMA ven to the imatinib and do that. But no, imatinib works really well in this group. So yeah.
So his blast like kind of settled with hydroxyurea alone. Like imatinib, I waited for 2 weeks for the molecular reports,
Yeah, I would do the
but
imatinib. Hydroxyurea
I
alone is
just
not therapy. Yeah, hydroxyurea
no,
alone is cosmetic.
no,
Even
it like it is theoretically cosmetic, but like it cleared most of the blast,
yeah, it's
and
not
we repeated
theoretical.
the marrow. Marrow is empty.
No,
Marrow is empty.
it's cosmetic. Yeah, it'll come back.
Yes,
If you want to
yes,
biologically treat the disease, you have to hit the
yes,
target. You can wipe it out.
yes.
If you gave 20 grams of hydrea, you will wipe out whatever is there, but it's not biologically actually treating the disease. It'll come back in a few weeks. So I would absolutely do the imatinib and continue that. That may actually give you a true remission with count recovery.
Sure. Thank you so much.
Thank you, Dr. Vishwadev. One last question from Dr. Dibyendu Day. Will CML with myeloid crisis will be treated in a similar way like AML?
Yeah, I mean, it just depends on what is the makeup of the blast crisis. But in general, yes, we do use HMA ven-based therapies quite frequently there, or intensive chemo. Obviously, you want to look for the mutations, FLT3, BACR able. So we do have patients who are getting clear with imatinib or better with ponatinib, and we've published that experience. But no, it doesn't change our backbone chemotherapy that much. It just depends on what you're going to add to it. Yeah.
Well, thank you so much. I finished all the questions from the chat box.
There we go. Excellent.
Anybody has any other question from the discussions for Dr. Naval? Well, so what a wonderful discussion. What a wonderful lecture.
My
Really,
pleasure.
it's always fun to listen to you. Every time new learning from you. Thank you for joining here today.
Thank you so much, Dr. Gurana. Thank you. Take care. Bye.
Thanks a lot. I now request Zydus Pharmaceutical to please go for final vote of thanks. Dr. Suyash, please take over.
Oh, thank you, Dr. Naval sir, for excellent session. Thank you. I would like to thank MSG for giving us the opportunity. Thank you, Dr. Amit Khurana sir, for excellent moderation, sir. Thank you. Good
Thanks.
night.
Good night.
Good.